Suicide is the leading cause of injury-related death in Hawaii, according to health officials. An average of 190 people take their own life each year, while nearly 1,000 more survive a suicide attempt. There are many causes, including depression, significant life changes, and abuse. Suicide can be prevented, and anyone, including you, can help. Tonight's live broadcast and live stream of Insights on PBS Hawaii start now.
Aloha and welcome to Insights on PBS Hawaii. I'm Yanji Denise. Suicide rates in Hawaii have risen steadily over the last 15 years, especially among teenagers and young adults. State data shows that an average of 190 Hawaii residents died every year from suicide between 2013 and 2017, outpacing fatal car crashes, homicides, and drownings. A state task force report submitted to the legislature 2 years ago called suicide a, quote, serious and complex preventable public health problem. The word preventable is the focus of our program tonight. Joining us are our mental health care professionals, including a psychiatrist from Maui and the sibling of a suicide victim. We look forward to your participation in tonight's show. You can email, call, or tweet your questions, and you'll find a live stream of this program at pbshawaii.org and on the PBS Hawaii Facebook page. Now to our guests. Metisa Gass is a program director for Mental Health America of Hawaii. She's a clinical psychologist and a member of several task force projects dealing with suicide and mental health. Jill Oliveira Gray is also a clinical psychologist. She has worked in medically underserved communities across the state of Hawaii. Adam Coles is a psychiatrist and clinical director of the Maui Family Guidance Center. And Kathleen Merriam is a social worker and, like too many in our community, lost a family member to suicide. Thank you all for being here on this very important topic tonight. I want to start with you and drill down those numbers a little bit. 190 every year across those years. Someone on our staff put this in perspective saying, wow, that's almost one every other day. When you think about that, why have we seen that uptick, and what is unique about Hawaii when we talk about suicide?
So I think that when you start talking about it, that you said it very accurately from the task force report, which is it's very complex. So there's a lot of myriad factors as to why we see the rise. Another thing to kind of note is that the greatest increase that we've seen is with indigenous groups. And so that could explain some of what we're seeing here in Hawaii. We need to have access to care. So the fact that we have so many people living in rural areas, and we also need to have culturally competent care. So when you're looking at those two things, that can be very difficult to find. And those are the big things that I think we have to start talking about is what is the cultural pieces that also play a role in this, including willingness to talk and to be open about what's happening in our communities.
Dr. Coles, I wanted to ask you, because when we look at those numbers, we are seeing the uptick in youth in particular, and I know that's the patient population that you deal with. What's different about what youth are facing today, you know, even in the last decade, than in years past?
That's a great question, and there's a lot that's different. I want to completely agree with Ms. Disa that it's multifactorial, and also it crosses all age boundaries. So it's from very young youth that we're seeing. When I first started in psychiatry, we didn't see that much, and I worked in the inpatient setting, really young folks, 10, 11 years old, having suicidal ideation or behavior, and now we're seeing that age group. We're seeing more suicide attempts among, adolescent youth and young adults, and that really is kind of a gray area where people are trying to mature and grow up and get out there. I think social media can be a force for support and comfort with peers and family, but it can also be a source of bullying and negative imagery. I think it's being young, and especially being a teenager now, is more stressful than it's ever been before, for a lot of reasons.
One of the things that she pointed to was the rural communities, and obviously we have a geographical challenge here. Can you talk about what are the particular challenges when it comes to rural communities, and why, and some things that might be done to help those communities have more access to care?
I think one of the biggest things is the difficulty accessing services. So behavioral health care, significant gaps. I think one of my biggest sort of changed experiences when I was working on Molokai was trying to get somebody inpatient here on Oahu who was in a suicide crisis. And it took more than 24 hours to go through the process of getting the person medevaced and to Queens, and there weren't any beds, and taxi cab to Kahimohala, and by the time all of this, patient decided she didn't want any of it, and so ended up back on Molokai within about 24 hours. And after that, I realized, just the hurdles that people have to face in order to get care when they need it. It was just not there. So part of the work that I've been involved in is integrating with other healthcare providers and medical settings in rural areas where folks are, they're known entities. People know their primary care providers. And so when we started working out in rural areas, we worked with providers who were there to kind of decrease the stigma of talking to somebody about something like depression. And that also helps us to get to people before they fall over the waterfall, and so you're identifying problems earlier and hopefully getting folks care before they reach a place as desperate as wanting to kill themselves.
Kathleen, tell us a little bit about your brother and some of the challenges that he faced.
My brother Michael really suffered a great deal with depression, and he would use some drugs to, I think, just self-medicate, probably just to help hide the depression. He was 27 when he took his life, and he had attempted a couple times before, which is really, I've learned, is a huge signal for somebody to be at high risk. So he's been gone 14 years and 5 months, I think 2 days. So sometimes it feels like that long, and then sometimes it feels like it happened yesterday, which I think is something typical with grief. And he was vibrant and wonderful and beautiful, and really like the fire in our family. And so we're lost. We're still lost. The gap is horrible to deal with. So the way I've kind of dealt with the healing is to get involved with suicide prevention, because I feel like if I can do anything to help another family or mental health professionals deal with this, then I could, it somewhat helps me. And so that's why I've gotten involved. But Michael was amazing, and I feel like he's still present and gives me strength to do this.
One of the things that that everyone on the panel already has identified is this access of care question. Did he have access to care?
He got care, but I would say that the care, many people, even professionals, don't necessarily ask the right question. I have learned that it's important to be really clear, to go ahead and say, are you thinking about killing yourself? And though that sounds really blunt and direct, if somebody asks the question, are you thinking of hurting yourself? That's not clear enough, because many people think it's not going to hurt. I actually want to go. I actually want to die, and it won't hurt, so they'll say no. And so I think it's been great for me to learn, and we actually do that in training, have people go around and hear themselves. Actually, it feels strange to actually say, are you thinking of killing yourself? But it's important to be that direct. So I don't think he ever had anybody actually ask him that. And the care, actually some care that he did get on his attempts, if you are not a danger to yourself and others at the moment, you will be let go and asked to leave. And so even after slitting his wrist, he actually, as long as the blood was dry, he actually went home right after. And so I think we have a lot to learn about how to deal with emergency rooms and other providers. So that's an initiative of what we're dealing with at American Foundation for Suicide Prevention, is to try to help train people to ask the right questions and to provide that care at the moment they see people. He saw a physician that day, his primary care physician, the day he took his life. So, we've learned a lot.
Can I jump in on that?
Absolutely.
Totally agree. The time course is so key, is so critical. Not only the letter, but the spirit of our statute here when we think about like mental health holds. the danger to self or others has a window, and we really need to explore that window. And it goes back into the past, and also goes into the future too. If you think a person's going to be in danger, but I think too often it's in that moment. Are you thinking of hurting yourself right now? Are you hurting yourself right now? Are you in imminent danger? But we need to explore what's been happening the last few days, the last few weeks, the last few months, and really take that into account if we're going to capture folks who are in need.
And if we do want to put up a graphic, if you or someone you know is in need of help, these are some hotline numbers that we want to share with you. We'll be sharing them throughout the hour. Here on Oahu, you can call 832-3100. On the neighbor islands, 1-800-753-6879. Mestiza, I want to bring up something Kathleen said, because it's a really provocative question to ask someone. Are you thinking of killing yourself? What is the best way once you've asked that question and the person might indicate yes? Then what?
So I think the first thing to kind of talk about is the myth that surrounds the question, which is, if I ask it, will it make someone think about it who wasn't thinking about it before? And the reality is no. What they've seen across the board is by actually asking the question, people feel more relieved that you're also available to hear whatever the answer may be. And so if you're talking to someone and their answer is, yes, I am thinking about it, the important thing to know is never leave them alone and start to ask really specific questions about time frames. Do they have a plan? Do they have the means to that plan? And when are they thinking about doing it? Because that's going to tell you how immediate the danger is. And you want to make sure that if it is, in a very short time frame, that you start to let them know these are the choices that we have. We can call the crisis line. They can meet us here. But you want to make sure that a professional is involved, of course. Also going to the ER, calling 911. It's very important to do. If it is where they are thinking about it, but they don't have a plan, that they don't have a time frame that's immediate, it's important still to get a professional involved to help support the family. I think it's very scary for families when they have a member who's saying, yes, I am thinking about this. I would tell them, you can't be with them 24 hours a day, 7 days a week. So you need to be helping find someone who can give them coping skills, who can help process why they're feeling that way, but also give them the resources so that they feel empowered to use them. Because sometimes it is feeling empowered to make those phone calls and knowing that people are going to answer and that they're going to be taken care of. That's really important.
We have some questions coming in, and we want to encourage you to tweet us, call us, send a message on social media, whatever the method. Please do get involved in the conversation tonight. Jill, I want to pose this to you. Is the rate of suicide different? And I know Mestiza actually did talk about this right at the top, but is the rate of suicide different to different nationalities and different ethnic groups? You were saying that indigenous people are particularly at risk. Here in Hawaii, what do we see?
Yes, we're seeing higher rates of suicide amongst Native Hawaiians, particularly males. We see with the state data, though, that suicide attempts are more common amongst females, and I think that also bears out for Native Hawaiian girls, showing higher rates compared to other ethnic minority groups. And that might also be tied to, unfortunately, Native Hawaiians also have the highest rates of substance use, and substance use has been linked to suicide, increasing the risk to suicide, alcohol, ice, cannabis. So unfortunately, Native Hawaiians sort of top the charts on a lot of different things that are also risk factors for suicide, socioeconomic stressors, being in rural areas where the limited access to care. So unfortunately, they're right up there with all the different suicide risk factors as well. So.
And what you're saying actually ties into the next question, which was, is the increase in suicide drug related? So, our viewers see that connection as well. What are your suggestions for someone who might see someone in that circumstance? You know somebody has a substance abuse issue. How do you navigate that?
So you absolutely want to, as Mestiza was saying, assess for a level of risk with anything. So with substance use, you want to assess for a level of risk so that you know what treatment they're going to need. So if they're high level of risk, then you're going to want to try to get them into some residential substance use program. It helps you to know how how many resources you need to be pulling in order to wrap around this individual to help them with that problem. Assessing for suicide ideation, depressive symptoms, because we know that mental health issues often are comorbid with substance use as well. So understanding what's going on sort of in the whole picture, and so we can address everything with the treatment plan.
Adam, I want to ask you about young people again, and talking about that question that we had addressed earlier about, are you thinking of killing yourself? I think that a lot of parents have a hard time talking to their kids in general, and we might have parents watching tonight, or aunties and uncles, or other caregivers who might see a young person and not really know how to approach them. That's a very direct and pretty provocative question. How would you approach a young person that you see, that you think that you're worried that might be in need, but you don't necessarily want to further alienate them by asking them something like that?
I think the most effective thing I've run into is approaching youth with respect and with truth, and treating them like they know what they're talking about, they know themselves. Kids do not like to be talked down to, and they can detect falsehood very easily. And so we're very honest, when we meet new folks. We say, well, look, almost all of what we talk about in this room, if it's my office or whatever, is confidential. These are the things that have to go outside this room. If you're thinking of harming yourself, if you're thinking of harming someone else, things like that. And it's not a judgmental thing. It's just what has to happen. And kids respond really well to that level of honesty, and that if you respect their thoughts and their feelings, just like anybody else, that works the best. It doesn't always work. With parents, it's kind of the same thing. I think one of the things that teens are most sensitive to is the feeling of being judged, and that feeling of being negatively judged for having a feeling about yourself, whether it's to harm yourself, or that you're worthless, or something like that, is so powerful that if any whiff of that comes along, you're out. It'll climb right up. So we try really hard to make our places of work and homes judgment-free zones.
On a policy side, I know you've done a lot of work since your brother's death. What do you think that we could do as a community, or on the state level? What do you think needs to change to prevent suicide?
Well, some of the work that I'm really proud of that we have done is that there's suicide prevention task forces on every island, because it's important that every island kind of gathers together providers, survivors, policymakers, and really attacks plans for prevention and plans for making access to care a priority. So I think we have some things in place that we need to keep nurturing. I think that one of the things, for example, that the American Foundation for Suicide Prevention, the goal is to have by 2025 to have a reduction of suicide by 20%. And so there's some key kind of pushes that we're working on. One is firearms and suicide prevention. So not to just get rid of guns, because that's a whole nother issue, but to safely store them. And so we need to work on that. That's a complicated issue, but there's some actions that we could take that are pretty simple in terms of education. The healthcare systems that we mentioned, the emergency departments, and then also correction settings. So we have kind of key areas that we are trying to focus on in order to reduce suicide by 20% by 2025. So that's kind of what we've narrowed in on.
Let's talk about that access to firearms question, because that does seem like a practical thing that someone who does own a gun could do.
Yes.
What do you suggest?
That it's safely stored. Many people that have firearms, they're just in their house somewhere. I mean, they just keep it where they think is handy for themselves. And I'm not sure that people have put together that somebody could come into their home and get that gun, or that a loved one could, and that's what happened in my family situation is, and you can imagine the guilt that would be, I mean, just think about it, the guilt that's associated with somebody taking your gun. So I would encourage the people that are watching to really do something now, because you don't really want that association. So they have to be stored safely so that you don't have somebody coming in and taking them that might be suicidal. Even if you don't think anybody in your life is suicidal, you just don't really know for sure.
Well, and that brings up a good point. How do you know if someone in your community is suicidal?
There are definite signs. You know, you want to look for drastic changes in mood. There's another fact about suicide that folks often do talk about, wanting to hurt themselves or kill themselves, or feeling like there's no purpose in life. So you really want to listen to people in your life, coworkers, you know, so we all can be, I know one of the state training initiatives is gatekeepers. And I think, again, we were talking earlier about the kitchen sink approach, and I think the training has been phenomenal, and I think really reducing a lot of the myths around suicide and empowering all of us to realize that we can be first responders and detecting when folks are at risk, you know, some of those warning signs. I think they are very evident. You see people pulling away, you see them having changes in activities, you know, things that they used to enjoy, they're no longer doing. They're starting to isolate themselves. They might look different. So there are behavioral changes that if you know this person pretty well, you'll be able to pick that up. And you want to move toward them, not away from them at that point.
And I think some of those things would be things that if you saw in a teenager, you might write that off to, well, he's 16. You know, we've all, you know, hormones, and he's tired, and work is hard, or school is tough, or, you know, whatever it may be. How do we recognize teen angst versus something much more serious?
Yeah, I think it's change is the number one thing. And I love that idea, just to go back a little bit, that everyone can be a first responder. That's a kind of message we're trying to send, although I'm going to steal that message. I like how it's worded. I was at a luncheon last fall and was asked to talk a little bit on this subject, a little sideways, and really focused on how everyone can have an opportunity to interrupt that pathway to a completed suicide, because there are many moments where that pathway can go sideways to something else, and you never know where you're going, if you're going to be one of those people on that path where you could be just 1 ounce of pressure to go somewhere else, to take a different path. And it can go all the way up to the moment, you know, taking that gun away, all the way back here to maybe you should talk to the school counselor. So friends, you know, I talk to a lot of adolescents and middle schoolers. Friends are a powerful support. They can be. So they have told each other in the hallways, they've seen each other's texts like, hey, you should go to the school counselor. And they'll gang up on a friend, you know, and get them to go, even if the parents don't know. And then someone gets picked to connect parent to parent. So they can really be a powerful influence there. And teens and kids can text 741-741 to get help. So it doesn't have to be over a phone call, you know, which might be less comfortable.
And that ties into a question that we just got, which is what resources do our schools and teachers have to help spot potential victims? Are our teachers and our, you know, the people in our education system equipped with enough tools?
Yeah, I think there are tools. I probably will never have enough, but you know, the schools have the behavioral health specialists. They have grade level counselors and SSCs who kind of work the behavioral health side, and DOE does a really nice job working with us at Department of Health.
What's an SSC?
I'm blanking right now.
Okay.
Sorry. They sort of oversee the behavioral health specialist
Okay,
side,
gotcha.
the behavioral health side within the schools. That came out of the old Felix consent decree back in the late 90s, which followed a death. But there's always more. I think schools utilize on Maui and our neighbor islands the crisis mobile outreach workers. We call them CMOs. And they're available through the crisis line and will dispatch out within 45 minutes to most places Hana gets a little dispensation because it's a little farther out, but and they can arrive on scene and do a crisis assessment, and they can recommend hospitalization, for instance. So it's a really good resource. And we at Child Adolescent Division get all those reports and can outreach the family and get folks enrolled in services, or they can do a direct application for our services. So there's a kind of loop that can close.
And the legislature did just allocate dollars through the injury prevention branch. A lot of funding for education for the schools. So I know they're doing Safe Talk. We have Safe Talk, and then we have like a Suicide Prevention 101, and that's happening right now, where the teachers are getting some training. So I think that's made a big difference.
And I would be remiss if I did not mention that Danielle Bergen, who's our Mental Health America Maui coordinator, and her trainers have been teaching youth suicide and bullying prevention courses. I don't know how many schools they've been in now, 13 to 16 something schools in Maui County. So they've taught hundreds of students and teachers. And we're into the cycle of repeating some schools because they have new kids and they're in the middle schools. To my knowledge, they're not in the elementary schools yet.
We actually, so that's Mental Health
starting?
America Hawaii, yes. So we were looking at intervention and prevention. We decided that it needed to be age appropriate and developmentally appropriate.
Right. I mean, even when you say middle school, to me, that strikes me as kind of young to be having this conversation.
So the conversation there works on learning about emotions, negative and positive emotions, how they can impact you, resources for who to talk to, how to cope with those kinds of feelings. And what it does is it just helps them recognize things and focuses really on bullying prevention, just to be able to make it safe to talk to another peer about that and reach out to adults. When we move into middle school, we do suicide and bullying prevention. And now our new curriculum for high school is going to include coping skills that we want them to take away from. So we're reviewing, and at every level we're building to make sure that people have what they need, because we know that the attempts are high for 15 to 19-year-old. And so if we can give them the skills before they get to that point, then they're more likely to utilize them.
And is this something that a counselor would come in and give a workshop to an assembly, or how does this actually work on the ground?
So there's a lot of different trainings, and I think the piece of legislation we were talking about was Act 270. It's a big win for us. It is asking that all of the teachers, assistants, administrators, and counselors be mandated in suicide prevention and awareness. So we are really happy when that passed. There's a couple different programs, like Kathleen mentioned, that are being used. Ours happens to be one of them. So if they're interested in getting some of those trainings, they just contact us or the Department of Education, because they're all linked up and they're all providing that care. And they're doing a really great job trying to make sure everyone gets that training. Ours just happens to be particularly through us, and so we would be training trainers to go out into the community to provide that. So we also go into school systems and teach the youth. Because, like we were talking about earlier, about 85% of people are going to say something first. And we know with youth, it's peer-to-peer. That's who they're going to tell first. And so we really want them to have an understanding that, stigma needs to be decreased across the board so people can talk about it. There's a safe space to talk about it, and people who can hear it and do something supportive about it.
This caller, Miley on Molokai, is writing in, how can I support my nieces and nephews from being attracted to suicide in high school and middle school? If you are on a neighbor island and you feel like there might be some concerns for her nieces and nephews, what would be the advice there?
I would maybe check in with the pediatrician that the children are with, or with the schools, with the school counselors, or who are important other people in her niece's world, and talk to her niece about would it be okay to talk with these individuals, or just to open up dialogue. I think that's the biggest thing. One of our biggest messages tonight, I think, is to be okay talking about this. And if she's concerned, approach her niece and ask her how she's doing, open up the communication there, and then sort of see who else is important in her world, and try to get everybody sort of on the same page and connecting in.
Kathleen, Adam talked about those moments that all throughout, at the moment at the end of being able to take a gun away, to the moment at the maybe beginning, maybe you should talk to someone. You said that in your brother's case, he had actually seen a physician that very day. What are some of the moments you think that were missed along the way? I mean, you also referenced that he had had 2 attempts in the past. And what can we learn from that?
Well, we can learn a lot. I would like to believe that I and we did everything that we could to keep him alive. But I'm often reminded that medication could have really helped too. I mean, medication today is so much better than it used to be. And he was on some medication for a while, and then he didn't like the side effects, which is why he went to that physician that day after all my investigating. And I think working with people about understanding medication, sometimes people just get the message, just take the pill, just take the pill. So I take a lot of pills because I have bipolar, but when people tell me just take the pill, that turns me off. I just want to say, you take the pills, you take that. You try taking some of this stuff. You try getting some of these side effects. That's not empathy. So if you really listen to people about their struggle with medication, I think then there's hope. And I think that he had a chance with some medication, and him rejecting that, which I see every day in my work too. People, it's a dance. It's that relationship you have with somebody about talking about medication. And so I really believe in that therapeutic relationship of people finding somebody they can work with to give medication a chance, because the depression can kill. And I think that's part of what happened to him is he didn't think that would go away. He didn't believe that he could have brighter days. And so a lot of people that do die by suicide, I don't think they necessarily want to die. They want that pain to go away. And so that's what we try to work with, right? That ambivalence. People, they don't necessarily want to die. They just want that to go away. So I have learned that from Michael, that I can't bring him back, but I can help others by what I learned with him.
Can I celebrate, by the way,
Yes.
that you shared, that you have bipolar? That's not who you are, but it's just a thing. I love that we need to destigmatize, mental health issues across the board. I think that's part of what makes it hard for people to talk about these things.
Absolutely.
And we're taught in therapy training, at least I was taught in my training, not to overshare about ourselves with patients. I totally get that, and I don't much. But once in a while, I'll let a youth know that I have ADHD. And I think it lets them know that you can have a life and be successful and do cool things, even if you have one of these, diagnoses. It doesn't define who you are. I just drink a ton of coffee, and it doesn't change who you are. And as soon as we can really begin to get over that, I love that. So I really respect and appreciate you did that. So
Thank you.
Very
Thank
cool.
you.
We have more questions coming in. The caller would like to know if there's a correlation between suicide and sexually abused individuals. You talked earlier about substance abuse, but what about sexual abuse?
Sexual abuse is a very difficult experience to endure. It's a traumatic experience, and trauma can definitely lead to a host of other problems as a way to self-medicate or as a way to get that pain to go away. So substance use is often a way that people try to deal with that trauma if they're not in treatment. And so yeah, if it's not treated, if people aren't able to talk about it, then it's it's relegated underground, and it's only going to bubble up in many other ways that are devastating and harmful for the individual, and suicide could be one of them. Oftentimes we see depression, again, if it's untreated, then everything just gets worse. It's just a snowball kind of an effect, and so we can absolutely see the person going over that waterfall if we're not able to get to them sooner.
Right.
In dealing with that, because it's not easy.
And again, we want to give you those resources tonight if you or someone you know is in danger of hurting themselves or just wants to talk to someone. The numbers there on your screen, 832-3100 for Oahu and 800-753-6879 on the neighbor islands. These problems are so complex, these issues are so multifaceted when we're dealing with sexual abuse, mental health issues, substance abuse, all sort of leading to this one apex.
Right.
When we look at how to address this from a policy perspective, is this purely a financial challenge? Is this something that we can throw money at and fix, or is there, what is the solution?
That's a big question.
Yeah.
And I'm looking to you to answer it.
I think that when you're talking about, of course, that always helps. Finances help us do the programs that we need. But we also have to start getting really creative about where we're going and who we're providing these trainings to. So recently we were invited into a church who let us provide them with a mental health first aid training, and we were really impressed and really happy to be able to get into the faith-based community. They've been also doing their own faith-based trainings that are specific to them, such as Soul Shop. And just understanding that it's not always a psychologist, a counselor, or even a psychiatrist. It's not us that often hear it for the first time, that first kind of warning shot that says, is everything okay? That it could be a family member, a teacher, a peer. It could be a primary care physician. It could just be, a front staff at a different office, and making sure that as many people as possible are well educated in how to be a good listener, how to ask the question and ask it in a way that doesn't provide the answer. So instead of saying, are you thinking about killing yourself? No, right? So now you're giving them the answer and the response that you want. And so being just a really good communicator, not providing the answer, whether it's with your body or through like the next sentence that you say, and just letting them say it even when you're uncomfortable. That's important. But the first step is always like, let's decrease stigma across the board, because people who are coming from all these different backgrounds, whether it's having survived sexual assault or sexual abuse, whether it's someone who's suffering with depression or have other things that are happening, they're still also experiencing stigmatization, and that impedes their care and their access to going out there and seeking treatment. And so if we can start saying, mental health is really important, that's a priority for us, and making sure that we can talk about that in as many ways as we need to. I think that we've seen people do a really great job when it comes to physical health. In making things more accessible and more comfortable to talk about, such as, people done a really great job in making cancer more comfortable and saying, this is happening to me, or this is happening to my family, can you support us? And we don't really see that as much if someone's having a child who is, suffering through severe depression. No one's bringing a casserole. So we need to make sure that people understand this is impacting their day-to-day. They do need support. They do need to feel comfortable talking about it. So yes, finances would be great, but the first step is saying, it's okay to talk about this. This is happening in many, many homes.
Right, and many different communities. I mean, one thing that, when I was doing some prep and reflecting on this, as someone who knows a lot of, I have a 3-year-old and a 1-year-old, I know a lot of mothers in similar circumstance, and there is a lot of postpartum depression and issues around that. And it's not something that's often talked about, because you have a baby, it's supposed to be the happiest time, but there are so many challenges with that. That I think you're right, that just having those conversations is really important. So let's continue to have them. Something that a caller wanted to talk about was something that you referenced. Is there a higher number of suicide linked to newer drugs like opioids? The caller doesn't think there's a link to marijuana. Do we know the specific sort of lanes when it comes to different kinds of drugs? The influence.
The influence. I mean, I think all substances have associations with mood alterations, and with cannabis, the long-term use of cannabis in terms of some more serious mental health issues, the research is still out on that, I guess, because the legalization is just happening, so we're just starting to possibly be able to look at that, the effect of long-term cannabis or marijuana use, but definitely with some of our other substances like ice and the ones that we've known about for a long time, cocaine and now opioids, there's some absolute physiological changes that are happening in the body, and so that's probably impacting mood as well, and we can then see a lot of the same problems, whether it's during the withdrawal phase or during the intoxication phase, in terms of either euphoria to depression to anxiety. So we absolutely see the range associated with different substances.
I think we need greater freedom to research the effects of these different things. One of the challenges with working with Schedule 2, Schedule 3, Schedule 1 substances is the research side, to get the permission, get the funding, get federal permission to research these things. Only now we're beginning to find research coming out that some of our sort of old friends like LSD might actually have a therapeutic benefit for certain very focused things if used appropriately, but that's 30 or so years after, they were really, or 40 now. Geez, I'm old. But anyway, when we could have had 40 years of research and really understood these things so much better, so we could really crack this open a little bit more. It's hard, right? Because you can't harm people. But we have lots of really good rules about how to do that. I think we could be successful if we gave ourselves permission.
Kathleen, I wanted to go back to something that you had talked about, which was having those difficult conversations. If there's someone who's out there who wants to have that conversation and might not know how do we help the helpers? What resources are out there for people who want to broach that conversation but really don't know how?
So I have two websites that I frequent the most. I realize that doesn't help everybody because not everybody has a computer, but so the National Alliance on Mental Illness, NAMI.org, NAMI.org, is for family members and loved ones of somebody that might be struggling. And you can get tips on how to talk to people. You can get fact sheets on mental illnesses. Lay people, people that aren't psychiatrists can get some understandable resources on diagnoses. Suppose somebody actually gets a diagnosis and they're like, I'm not sure what that even means. They didn't really cover it that much and I want to understand it more. So I find that resource very helpful. AFSP also, AFSP.org, because that's where there's all kinds of information about suicide prevention. Those are two resources that I personally use a lot. But in terms of what you could do, and they also then will link you to the local chapters for here in Hawaii. I need to add that. But I think learning about suicide prevention is the first step, and just, you mentioned it before about just staying with the person, trying to be with that person as much, and really just good old-fashioned listening. You don't have to do anything particularly fancy other than having some empathy and listening to the person that you care for. And if you can get them to a mental health professional, great, but you are doing a great service by listening and just being there. And if you don't know what to say, that's okay too. Just be there with the person.
That's great advice. One caller wrote in or called in saying, how does Hawaii compare to other states per capita for the number of suicides annually? I know at the top we referenced that we are second in the nation. How do we, obviously that's not a great place to be. Why is that?
Why is it that the rates are so high?
Yeah.
For a lot of the reasons that we already discussed in terms of people living in rural areas, the access to care, and I think that it is a new generation that we're looking at, and there are a lot of different challenges that are specific to it. I think when we talk about social media, it's really important to understand that I'm also very old, and I grew up in a generation where I remember not having computers, and I remember the first cell phones, and that is something that's just taken for granted with the new generation, the younger kids, and so they're being impacted in ways we can't even begin to understand. The research is beginning, but it's just not able to keep up, and one of the things that we see is the cross-comparison issues and forgetting that this is a highlight reel, this isn't everyone's everyday, and not feeling comfortable to be able to say something. And I think that there has been a trend in saying that the youth are attention-seeking when they do say something. And so we always say, if someone says that they're thinking about killing themselves, or they're saying something about wanting to, injure themselves in any way, let's reframe it and say that they're attention-needing and not attention-seeking, and take it seriously every single time, because then that tells other people who may also be going through it that there's help and there's support, and it's not going to be dismissed. So, there's just so many factors as to why it continues to rise, and there's so many things that we have to put in place to try to slow it down. And so, it's kind of scary to think about where it would be if we hadn't, and how much more is needed to be able to help the kids have like great social emotional learning, to be emotionally intelligent about their use of social media, and to help parents understand like it is different how they see it than how we do. And so, the cyberbullying is different. It impacts hundreds, possibly thousands, whereas for us, when we were experiencing it, it was happening face to face, and it was a small handful. So just very different circumstances.
Yeah.
I think there's an environmental component as well. It got clarified for me a little bit ago. I read a sort of novel paper, and I don't remember the reference. I apologize. If one of our viewers can pull it up and put it on your website, that'd be great. But it came out of talking with some friends and colleagues on the mainland who were sort of surprised, right? How could suicide be so high in paradise, right? And but the paper I read proposed, I think, a very solid idea about an environmental, cultural difference experience, essentially, that we've all gone to the store because we all live here and experienced how expensive groceries are and how expensive it is to rent, or buy a home if you're lucky enough to do that, to drive a car, here. All of these stressors for folks who grow up and live here and have to work here day to day. It's not a vacation. It's just where you live. And so not only is that a fine enough stressor to really make life difficult, but then there's this whole other population of people who show up here and throw down their beach towel and have an amazing time and eat great food and then go away again, magically to wherever they came from. And kind of witnessing that process, the theory is that might generate some stress that's totally different. It's seeing basically a population of people who are having a totally different experience than you.
Living in your community.
Living in your community, and yet not being part of the community, and just sort of taking from it and benefiting from it. And it was a really eye-opening paper. It was a social science paper. But just, I had to sit and think about
Right, that there's this whole part of Hawaii that you might not get to participate in, depending on what the stressors are in your own situation. That's very interesting.
Well, that really taps onto the cultural piece, I think, here in Hawaii too, because we have such diversity here and such acculturation stress. I love that you said the word stress. It's one of my favorite words, but it's a serious thing. And in Hawaii, I think we do face a lot of socioeconomic stressors here, and then the cultural piece. And there's a really good measure coming out of Palo Alto University called the Cultural Assessment of Suicide Risk, and really trying to get into the fine details of what people are experiencing from that cultural perspective. If it's a minority stress having to do with sexual behavior stress, or acculturative stress, or just the social aspect of what that feels like being an ethnic minority. The Native Hawaiians are ethnic minorities in their own home, and so that right there is
a tremendous sense of loss there. I will not speak for any Native Hawaiians, but I'm half Native American, and my mom grew up on a reservation. And they live now on about 100,000 acres of what was 7 million acres of their territory around the Great Lakes. And they've all experienced this tremendous loss in their identity, who they were, and an agency. Their ability to decide what they were going to do and who they were going to be has now been totally determined by somebody else. That I don't know. I don't even know how to measure that kind of trauma.
We focused a lot tonight talking about young people and the youth suicide rate, but I know that if you look at the numbers of where the suicides are happening, it's in the youth and it's actually in the elderly as well. And so the caller wants to know if there's a pattern with elderly suicide and the breakdown for the multi-generational families. How do we address this in our kupuna population?
I think when you look at some of the studies coming out of Great Britain specifically, they have really pinpointed the idea of loneliness in the elderly community. Multi-generational homes have been a safe place for elderly people in terms of companionship, feeling connected, finding meaning. And what we've seen as we have kind of moved into different generations is there's been a decrease in multi-generation home. I think we still see that quite high in Hawaii, so that's a protective factor in and of itself. But the idea of loneliness, that this time period in your life that, you are losing more of your friends and your peers, and then, are there people that are engaged in coming to visit you and taking you to go to do things like grocery shop or just visit with you? So the things that they've been looking at in Great Britain is how do we help reincorporate people in this time of life back into the community in a meaningful way, and to make that a way that just kind of safeguards them more. And so conversations with the different senior centers, with different people who are working with that community is really important to be able to see what is their feedback, what are they saying about how we can improve that, specifically for Hawaii, because we definitely are a different makeup than we see in other parts of the country.
That ties back to what you were saying about just being with a person, doesn't it?
And I want to make a point about these statistics. We've been talking about numbers and different populations of people. If you really dive into the suicides that happen and the numbers, there's a whole block called Undetermined Deaths. And what's scary about that is that it's much worse than it is, than we think, because even at the time of when there's an autopsy conducted, and I learned this again through my brother, you actually have kind of an opportunity the family could actually change the cause of death. So we called it suicide, but it could have been a drug overdose. But we know it was suicide because my brother left a note. Only 25% of people leave a note when they die by suicide. What's alarming, if there's a whole group of undetermined deaths, is probably many of those were a suicide. So the problem with some of these numbers and data and studies is that it's a larger problem than we even are led to believe by some of the research. So I just want to get that out there about, so whether it's the youth or the elderly or whatever, it's just an overall larger problem.
I worry a lot about the elderly population because I think a lot of deaths could masquerade, right, as an accidental overdose, but actually be intentional.
Yes.
Or deciding not to take medication as a kind of passive move. And there is, to be frank, there's a kind of less urgency I find in some sectors with the elderly population, because there's an understanding sometimes that life, if you have chronic illnesses and chronic pain, you're coping with maybe a disability, that life is hard. And so there's a kind of, well, maybe people have the right to determine when they exit. And I can't speak to that, but it complicates things, right? And what if someone has a moment where they're just feeling like, oh man, I just can't take this anymore. I've got all this pain, I'm on all these, drugs and everything. But maybe if something happens and they connect with a loved one or a friend, that could get them over the hump, and to the next day. I don't know.
I think it goes back to all those things that you were talking about those moments, right? And being the person in those moments. We only have about 3 minutes left, and I want to give each of you a chance to just give us a final thought, which I know is lots of pressure, but I think you're all up to it. And I'll start with you. The theme of this is prevention. What do you think we as a community need to be doing better when it comes to prevention?
When it comes to prevention, I think, just kind of taking individual accountantship and to say, like, this is something I need to learn about. And it might not be something that's happening in my family, but it could be something that's happening with a friend or a friend's family. And just really taking the time to educate yourself, see what's out there, look at the task forces, see where you can do volunteer work or training to learn more about it, because eventually someone in your life will be touched by this, and you definitely want to make sure that you're in a place to be able to help them. But the other thing is, we've been having a very heavy conversation, but really what I want to highlight is there's always hope. There's hope. We're making change. We're doing a lot of great things, and that with the right interventions and the right support, people can get better and can live very successful lives.
Okay. What would you say to that?
Totally agree. I love that you brought it back to prevention, right? And I want to move that prevention line further forward. Because we've been talking about when folks are already struggling. So how do we prevent that struggle? And I think that's what on Maui we've been working hard. We stopped trying to have just a separate suicide awareness event, and we began to infiltrate like the Office on Aging Senior Fair and Maui Comic Con to have a table and really get ahead of these things and celebrate life and get involved. Physical activity for every age group, huge mountain of evidence, it's helpful.
I think so. We just have 1 minute left, and I know I want to get to both of you, so if you would let us know what you think is the best thing that we can be doing.
I'll keep it short. The word that keeps coming up for me right now is connection. I think in this day and age, because we're living in a place where we have to often work 2 jobs and we have multiple kids and life is stressful and we forget to connect. We have to put our phones down. We have to do quality time with our kids, with our parents, with our family members, with our friends. You know, we sort of have this obsession with time and doing more, but the doing more, I think, is we need to connect with each other.
Okay, and Kathleen, I'll give you the last word.
Oh, thank you. Just thank you for talking about it. Keep talking about it and be hopeful. And yeah, thank you for keeping the conversation going. That counts. Keep talking about it.
Thank you for being here. Thank all of you for joining our conversation tonight. We, of course, thank our guest, Ms. Tisa Gast, Program Director for Mental Health America of Hawaii, Adam Coles, Clinical Director of the Maui Family Guidance Center, Jill Oliveira Gray, Clinical Psychologist, and Kathleen Merriam, a social worker who lost a family member to suicide. Next week on Insights, we're going to take a closer look at Hawaii's physician shortage. Why is it so difficult to keep doctors here in the islands? Please join us then. I'm Yanji Denise for Insights on PBS Hawaii. Aloha.